Good afternoon, Facebook family, Zoom family, the United States, all people interested in health, Black Health Matters family, all Health Matters family. I am so delighted to be here to talk with you about something that's incredibly pressing, which is COVID. And we have none other than Dr. Vin Gupta. And again, I hate to be a fan, but I am such a fan. We love him and the energy with which he presents and brings it when he reports. It's truly heartfelt and we know where it comes from. He's such a passionate practitioner. So we thank you for being here, Dr. Gupta.
Thank
I'm
you
going
so
to,
much, Rosalind.
yes, I'm going to introduce him now. Vin Gupta, MD, is a critical care pulmonologist and chief medical officer of Amazon Inc.'s global COVID-19 response. He is also affiliate assistant professor of health metrics sciences at the Institute for Health Metrics and Evaluation, part of the University of Washington. In his clinical role, Dr. Gupta has been caring for the critically COVID patients since the early days of the outbreak in Seattle. His role at Amazon is focused on leading the company's pandemic response to scale testing for all fulfillment centers worldwide and related workplace health and safety efforts. And so now, with great pleasure, I introduce you to Dr. Vin Gupta.
Rosalind, thank you so much for the invitation, and it's an honor to be here to talk about COVID-19 and then specifically its impacts on the African American community and communities of color more broadly. I have a series of slides here because I think it's better to not just speak in the abstract, but to hopefully help guide through illustrations and pictures. This is my contact information, my email at the University of Washington, and I share often content on social media, so and interact frequently. So if you're so inclined, I'd love to also interact with you on that platform as well. But thank you again. It's an honor to be here. What I'd like to do for the next 20 or so minutes, and then hopefully open it up for questions, is just provide us a current state of where we are in this pandemic and where we think we'll be in a few months, using data and try to really root ourselves on what we know, to the best of our ability when it comes to forecasting where we think things are going to be going in the next few months. And then I'm going to end on sort of a general discussion of some policy debates that I know exist in our country right now about the best way to reopen and related matters. And I thought I'd give some voice to it, and then perhaps that can engender some discussion as well. I say also, please forgive me. I just actually got off an ICU shift here, so I didn't even have enough time to shower. So I'm embarrassed that I couldn't freshen up. But if anything, it just goes to show how unpredictable the last year has been. This is, and I wanted to lead with this slide because I thought that this is the most sobering part of this pandemic, is that sometimes you can get lost in the numbers, but charts like this really, I think, ground me at least that what we're facing here is truly extraordinary and hopefully once in a lifetime. But week over week, for the last several weeks, at least 10 weeks, COVID-19 has been the leading cause of death in the United States. Early on in the pandemic, that wasn't necessarily the case. Ischemic heart disease, which is kind of our fancy jargony way of saying heart disease, or people dying of heart attacks, used to be and generally is the leading cause of death across the country, particularly in communities of color. But what we're seeing is COVID-19, in some cases, we were losing upwards of 25,000 Americans every single day for the last few weeks of December through really early February. And now it's slowly coming down, but we see, of course, 14,000 deaths just in the last week. We've become numb to these numbers. Somehow that's okay. It's not okay. We're not out of this yet. And as all of you know here, the burden of this death toll has been borne by Black and Brown communities. Let's just say it as it is. This has been a a pandemic that has wrought uh, disproportionate impacts on specific communities, Black and Brown communities. If you're African American, or if you're Latinx, you are 2 to 3 times more likely, if infected with this virus, to pass away from it. And I can speak to that both from the data and from what I've seen when I've been caring for these patients at the bedside. And I don't necessarily feel like our response has always been consistent with that reality, but I'll save some of those comments towards the end. But this was sobering to me. This is right now, and all these data points, all these maps are derived and built by my colleagues at the Institute for Health Metrics and Evaluation at the University of Washington. So I want to make sure credit is given to them, and for them allowing me to share these with all of you. But this is the most recent set of data that was released just this week. And this is our estimate, we think, about the percent of individuals at the state level infected with COVID-19, or who has at some point been infected with the virus. And I thought it was pretty extraordinary just how different it looks based on the state. California, we think maybe somewhere between 15 to 20% of individuals have been infected, but that number in New York, maybe greater than 30%. Really, truly, sort of an astonishing spread here. Anywhere from less than 5% in places like Vermont to greater than 30% in places like New York. Especially considering their neighbors, that's even more surprising. But it's relevant because we think that the vaccine, especially maybe these 2-dose vaccines, maybe only one shot of those 2-dose vaccines, if you've been previously infected with COVID-19, and if we can verify that through, say, an antibody test, maybe you only need one shot, is what some really compelling data coming out of both Israel and elsewhere is suggesting. And if that's true, then we can instantaneously free up some doses to immunize more people, which is a good thing, because the only way we're going to get out of this pandemic by midsummer is if we ramp up vaccinations quickly. And I think we're making progress to that effect. People refer to vaccine hesitancy. I don't like that term. I think there's no good term here. But especially for Black and Brown communities, with I mean, just atrocious track records of medicine when it comes to what they've done to these communities with respect to clinical trials, and just the unethical behavior of our colleagues in the past on experimenting on whether it's medications or vaccines on these vulnerable communities. It is no surprise to me that when I hear from my colleagues, "Hey doc, how can we trust a vaccine when 9 out of 10 individuals in any of these clinical trials were Caucasian? They weren't us, and so how do we know the results of these clinical trials actually apply to us?" And it's a fair point. It's a really reasonable point here that people are not as confident in the vaccines. They have natural skepticism because they weren't adequately represented in the clinical trials. And I give that as a background here because you'll see that there's a huge spread again in vaccine confidence, which is the phrase I like. Who's open to it. And we think nationwide about 75% of adult Americans are open to receiving the vaccine. But again, the spread varies. And again, you're seeing Kaiser Family Foundation just came out with survey data amongst the states that are reporting this data in terms of who has received the vaccine based on race, ethnicity. And what we're seeing is vaccine uptake rates are much higher, double, triple in some cases, in white communities than in Black and Brown communities. And that just needs to fundamentally change. There's a lot of reasons why that's happening, but that has to change. I have some thoughts about strategies I use and I employ when I speak to these communities. But of course, and this is hopefully part of the discussion we'll have towards the end of the talk, but lots of progress here, lots of improvement needs to be made. We publish this graph every week in these daily data briefs, and I just wanted to give you a sense of what we're thinking might happen. there's no guarantees it will happen, but we think herd immunity means 70% of the population to some degree, 70% or thereabouts receives the vaccine by, say, midsummer. That if that's the case, we would expect that cases and more importantly, hospitalization rates and death rates will have so declined that we wouldn't worry about health systems being overloaded anymore if there was an outbreak, that we would be able to quarantine positive cases and really do that sort of test, trace, and isolate framework that we were talking about way back when in February, March, when we didn't have testing in February, March of 2020. Maybe we could return to that because and resume normal life, because most people would be protected from ending up in the intensive care unit or in the hospital, even if they were exposed to this virus because they've been vaccinated. That's what I think is going to happen. I think by mid-July, hopefully enough of society has received the vaccine so that even if we have coronavirus and its variants circulating in the ecosystem, it's not going to cause more than, say, the everyday sniffles, and it's not going to cause an increase in deaths. That's the hope here. I don't think cases will necessarily decline all that much, especially when the fall and winter of later in this year come about. I do expect cases actually to kind of come in dips and waves, but what I don't think is going to happen is that people continue to go to the hospital with COVID-19. That's what I think vaccination is going to stop, and that's really key. These are the daily, I just want to make sure that I leave enough time. Okay, I just timing myself here. These are the daily COVID-19 expected deaths in absolute numbers until the beginning of June 2021. We have our forecasts out to that time period. And there's three scenarios here. One, the green line is the reference scenario. What does that mean? That basically means that's what we think is going to happen. We think that is the most likely forecast based on existing policies across all 50 states, based on kind of just our understanding of what we think is going to happen with variants and making some educated guesses. The worst line, sort of, you'll see that there's this deviation here, here towards the end of March, early April, where we're expecting, well, if deaths can plateau potentially, they could plateau and we could have sort of no sustained decline if, and what's the big if the variants take root. And for example, the B1.1351 variant first identified overseas, or gosh, these variants have just the craziest names, but these variants we think are more highly transmissible, in some cases maybe even more lethal, and in some cases we worry they're showing some degree of resistance to the vaccines. Not entirely, and I'll talk more about that later. Not entirely. So the vaccines will still be very effective, even if you're exposed to some of these variants identified overseas. These vaccines will protect you still, all of them, from ending up with severe pneumonia and ending up in the ICU. But that worst scenario does suggest that maybe increased case transmissions in our communities from these variants, because at a time when not enough Americans will have been vaccinated yet. So remember, April to June of this year, it's not like everybody will have received a vaccine. So that's the worry here, that if the spread of variants picks up, because indoor dining is open now in 48 states, because we're opening schools, because people are tired, because you're seeing scenes out of Florida. Pardon me to anybody on the call who's from the state of Florida. I have nothing against you personally, but policy down in Florida has been a little interesting. And we're seeing some scenes here that, no one's masking in public places. We have a convention happening, I believe, in New Orleans, if I'm not mistaken, the CPAC conference, where people are obviously showing no regard for masking. I mean, these things will have consequences. So that's that worst scenario. Reference scenario is that we all continue to do what we're doing, which is wide adoption of masking, largely kind of buckling down still until you get the vaccine, and being vigilant, we expect that deaths will decline, and that's what we're hoping happens, because that's going to herald the end of the pandemic to some degree, and the return of normalcy to a large degree. And then universal mask scenario, we always put this in there because, masking, we were estimating that about 75 to 80% of Americans are wearing masks routinely when they go out in public. But if we increase that to 95%, we'd be talking about saving 35 to 40,000 lives. And so that's why we always put that in there, that we would be mitigating the loss of preventable life if we all did our part. And, unfortunately, we've just never been able to really hit that number. This is a similar graph of infections. So the prior graph was deaths. This is cases, infections. And I just wanted to provide both to kind of give you a sense of what's happening. Again, that worst scenario, that's suggesting that even in the next, starting now, essentially, sometime in March, that if the variants continue to take root, if mobility and human behavior continues, if mobility continues to increase because restaurants are opening, no one's, you just heard Dr. Fauci and Dr. Walensky say this on Friday, that this is not the time for governors to start loosening restrictions ad hoc. Keep continuing to do what we're doing has been part of the reason why cases have declined. And what we want to see is a sustained decline in cases, so that there's no chance for a fourth wave here. We want to avoid that. We want to keep cases as low as possible, vaccinate as many of us. That's the way out. And we have that light at the end of the tunnel. The worry here is that, well, this line, the worry here is that, well, human behavior is not going to allow for that. People are tired. We're opening up parts of society. The variants are here. Who knows what impact they're really going to have? We speak about these variants as though we really know what's going on. The truth here is we don't have the genetic sequencing capability in labs to truly know what's going on. So we don't really have a sense of how rooted these variants are in our communities. So we don't know what we don't know, number one. And two, there's a lot of potential unexpected events coming. There's some degree of uncertainty here because of what governors are doing across all 50 states and that lack of consistency. Reference scenario, though, if we can buckle down, if we can continue to do what we've been doing over the last few months, again, look at that curve. It's just like this curve here. By June 21st, that's where we have mapped out these forecasts to, June of 2021. No, that's not June 21st, 2021. That's just June 2021. By the beginning of June 2021, look at that number. Those cases are down in the 10 to 20,000 range. That is a huge difference from where we were in the beginning of the year, 400,000. I mean, it was just an astonishing decline. So let's continue to hope. Just because I represent the University of Washington, I didn't want to give you biased information because I'm a member of this institute. So I wanted to make sure you saw what other leading institutes and academic organizations are putting out there in terms of their expectations of daily death declines and what they've been modeling out. And there's a lot of, there's some differences here in terms of when people think we're going to see a really sustained decline. But if you just look here, sort of middle of April, we're all sort of in the same ballpark here. The folks in London at Imperial College are perhaps a little bit more optimistic than the rest of us. But there's general agreement that we're on the downslope as long as we continue to do what we're doing for the next few months as we await vaccination. I have a few more slides, and then I do see that there's some questions here. I just wanted to, this is a busy slide, but these are all 50 states on the y-axis, and then on the top, sort of the top x-axis, there's a variety of different policies that have been employed. So restaurant closures, primary school closures, what have you. Basically anything that's orange here suggests that there's really no rule or mandate in place to close schools or to limit the size of gatherings in an indoor setting, versus something that's shaded a color green suggests that there is something in place. So higher school closures, usually high schools in most states are closed right now because we're worried about in-school transmission amongst older children. And then gatherings amongst for large groups in indoor settings is also generally speaking legislated and prohibited. Although in South Carolina, for those of you in South Carolina, sort of weirdly, the governor of South Carolina says it's okay to gather with as many as 250 people in an indoor setting, which makes absolutely no sense. But we don't have enough time to delve deep into that. I will close this part by just talking about a few things, and these are issues that are important to me for a variety of reasons. As a clinician, as a public health doc, as somebody that believes strongly in effective science communication and equity and how we distribute, say, the vaccine. The things I've noticed, one is, I'm not a legal scholar, so I'm sure somebody could say, well, hey, then this is not possible. And there's sun shining in my face, so I'm sorry that if this is obscured or my face is obscured. But it's odd to me that we don't have a more open discussion regarding accounting for race in a vaccine priority schedule. If Black and Brown communities are impacted disproportionately from this virus and die disproportionately, we should actually have some factoring in of race, ethnicity in the distribution and the prioritization of who gets the vaccine first, particularly, say, within tiers. There should be some acknowledgement of that, because I think the lack of it and our unwillingness to go there in very direct terms, I think, erodes trust. It just does. So that's one. School reopenings, I'm sort of going, I know this might seem like I'm going in very different directions here, but just things that I've noticed, again, that can erode trust. School reopenings and prioritizing teachers and adult staff. I don't have an agenda here. I consider myself a clinician scientist that just wants to keep people healthy, no matter who you are. But it's odd to me that here we are saying for months, we need in order to be safe in a public setting or in a workplace setting, you need to have testing available, and you need to make sure ventilation, you need to make sure you're outdoors. And here we are with public school districts that don't have the money yet, at least, to stand up testing. It's really hard to stand up testing. I've done it a lot for organizations. It is not just flip a switch. You need resources, you need time. And it's not easy to rapidly, just amazingly one day change your ventilation system, especially in older public school districts, especially in urban settings that's primarily service Black and Brown communities. I mean, these are easy things to say in a guideline. They are really hard to do in practice well, which is why I've just said, if the goal here is to get our children back in-person education as soon as possible, which is definitely the goal, we all want that. Makes sense to me that we just vaccinate adult staff in these settings, so then they're protected against the unknown. And I think we should all be humble and recognize that there's a lot unknown about this pandemic, but a lot of people don't view it that way. And then lastly, building vaccine confidence. I think this could be a seminar unto itself. In 30 seconds, I'll say that I just posted this on Twitter, actually, and I felt like people engaged with it, because I actually think we've done, and this is a combination of media and the way in which science has been communicated, but I don't think people there's been too much of a focus and public litigation on percent efficacy of a vaccine versus, and comparing it to another vaccine. And of course, people are going to be like, well, why am I going to get the one that's, not 95% effective, when in reality, all of these vaccines are essentially similarly effective and amazingly effective, whether it's Johnson & Johnson, Pfizer, or Moderna, in preventing the progression of healthy lungs from looking like really unhealthy lungs. This picture here, this is a picture of a patient with severe COVID-19 pneumonia who died on life support. That's what all these vaccines protect against: hospitalizations and severe pneumonia leading to death. So if one vaccine isn't as good at protecting against sniffles, well, then you know what? It's not a big deal. We should just say it in simple terms, but then also show very graphically what these vaccines do protect against, and stop confusing people. And so that's been a pet peeve of mine. But I know my time's sort of rapidly coming to a close, so I'd love to leave some time for questions. I see a few are popping in here. Rosalind, should I just I guess look in the Q&A, or?
Yes, you can look in the Q&A, or I can, we have, do you prefer one vaccine over the other? And then it said, another question is, I'm unsure if I want to take the vaccine due to being in an experimental phase. To clarify, what are the ingredients in the vaccines?
So Johnson and Johnson is a little different from Pfizer and Moderna. All these vaccines, they don't have anything that should cause an allergic reaction. They don't have egg proteins, things of that nature. They're not. One of the biggest ingredients actually in the Pfizer and the Moderna vaccines is something called polyethylene glycol. I wouldn't know what that is if I didn't. If I wasn't a doc, I would be like, "What is polyethylene glycol?" But what it is it's basically it's an ingredient. It's like a sugar type substance, that a sugar type liquid rather, that actually is part of the liquid that you would drink if you're prepping yourself for a colonoscopy. It's strange, and yet this is part of also the vaccines that we're taking to protect yourself against COVID-19. Why do I say that? I say that, Rosalind, because it's rare that anybody's ever going to develop an allergic reaction to something that's as benign as this type of sort of very common liquid that's part of many types of medications and other sort of medical type formulations. And so that's actually one of the prime ingredients there, in addition to sort of the genetic material that is part of these vaccines that gets injected into your body that then your cells use to build immunity. So these are extremely safe vaccines. I mean, and severe allergic reactions are so rare, 5 in 17 million. In the first 17 million doses of the Pfizer vaccine, only 5 severe allergic reactions. And by the way, I can treat an allergic reaction in the morning and have you home by dinner time. What I can't treat is that severe pneumonia that I'm showing folks here. So that's one. As to which vaccine, I mean, I just got my mom an appointment for vaccine. Whether she gets Pfizer, Moderna, or Johnson and Johnson, I could care less. I could care less what vaccine I got, because all these vaccines are similarly effective at doing the same thing, and that same thing is keeping you out of the hospital and saving your life. And that's the most important thing here. That's what we should want vaccines to prevent. That's the whole point of a vaccine. It's not to prevent sniffles. And it's true. You're going to hear in the next 48 hours probably a ton of confusing things on media that I don't think does anybody a service. But it is true. Johnson and Johnson's vaccine does not protect as well against mild infection, meaning sniffles and a cough that you might have to battle at home. Pfizer and Moderna are better at protecting against sniffles from COVID-19. They are all equally effective at preventing severe pneumonia, Rosalind. And that's the key piece here. And so the quickest way to be able to plan vacation in the summertime and holidays together as a family while making sure everybody's safe is just get the first vaccine available. And no one's lying about that. There is no vaccine. There's not one vaccine is not better than the other on the things that matter.
Got it. Got it. Well, thank you, Dr. Gupta. This has been amazing. Again, hearing all of this data that's real, relevant, and, current in what's going on. So we thank you so much for your talk.
Absolutely. And Rosalind, I know there's a lot of questions I didn't get to answer.
28, Dr. Gupta. You were
yeah, I was going to say that please do share. For folks on still on the call, my email is vgupta@uw.edu. I'm sorry, I know the time here is limited, so please email me and I will happily answer your question if there's anything that would be helpful.
And Dr. Gupta, may we invite you back for another time?
Sure. Hopefully in person.
That'll be great. That's
So you
right.
don't have
That's what
this
we're
like
striving for.
yeah. This is rare, guys. Seattle usually doesn't have sun, so I'm not used to this.
Well, good. We hope the sun will continue to shine and shine on you specifically.
Thank you,
Have a
Rosalind.
great day, Dr. Gupta.
Thanks for the invitation. Bye.
Okay. All right, everyone.